Welcome to a Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health. And this is one of our regular updates to explore what is going on in the world of diagnostics. Very often the Cinderella of global health, yet so essential to understanding both at a population-based what is going on with existing and new infectious diseases, but also very important primarily from the personal perspective. What does it mean for an individual? And how can they get the best treatment, and how can they monitor that it is continuing to work for them? Well, and as always on these diagnostic conversations, I'm delighted to be joined by Ben LaBrot from Roche Diagnostics. He is a physician working both in the industry, but also, of course, as a non-profit leader in his own right. Ben, it's great to have you back on A Shot in the Arm. Where are you at the moment?
Actually, on my last day in Panama, wrapping up a bit of a roadshow through Latin America and Peru and Brazil as well.
So we've not spoken since just before the AIDS conference in Munich back in July. And I guess in your travels, you will have been at the R4P conference, also organized by the International AIDS Society in Lima, Research for Prevention. What have you learned? What have you picked up over the course of these conferences?
You know, the R4P conference mirrored in many ways the messaging from the main AIDS conference, and seeing some of the same themes, which are, again, the need to increase access to treatment, the need to increase access to diagnostics. One of the things I really noted at this more recent conference was the big emphasis on integration, of kind of siloed HIV and STI and hepatitis services with other services. And also a big emphasis at R4P on the need for options and choices, that patients, countries, all the stakeholders, all the way down to the patient, really need a broad menu of different options for both prevention and diagnosis and treatment, so that patients can really be empowered to engage with options that fit their own lifestyle and fit their own needs better. And I couldn't agree more.
So one of our co-hosts, Yvette Raphael, will be very happy to hear you raise choice. That's something that's very, very close to her heart, particularly as it relates to options for women and girls with HIV prevention. But we're really going to focus in on this integration question in this podcast. And, on one hand, it makes a great deal of sense. Don't have siloed tests for individual infectious diseases. Go and get a test that can connect with, that can provide information about a range of things. And I guess we're not quite at the point where this is a reality, although we're getting there. What have you learned around integration since Munich and then coming out of Lima?
Prior to Munich, actually, I saw a really interesting paper that was looking at emergency room visits in the U.S. This was in the U.S. And they went back and looked at several thousand emergency room visits where the patients were attending for a broken wrist or a stomach pain or whatever. And the people doing the study looked at these case histories and went, now this person really had indications for HIV screening, but of course received none. And they went back and followed a lot of these and found out, how many of those patients eventually went on to be diagnosed in other settings. And it was a staggering number, like 7%, of these were just totally missed opportunities. But in a world of increasing medical specialization, it can become quite difficult to get providers to kind of think outside their lane. And there's this weird disconnect between the way things are being practiced, because that, of course, was in the US. Every country I visited on this trip, the complaints are often from the hepatitis researchers saying there's a totally different body working on HIV. There's a completely different office working on STI. TB is way out here. And like in Brazil, for example, in Peru, one of the investigators that hopefully we'll be doing a study with soon, was really complaining about the difficulty of high rates of co-infection with tuberculosis and HIV in Peru. Peru has absorbed about 2 million Venezuelan refugees, essentially. And quite a number of them were HIV positive and also had TB. So now into their country has this huge influx. It's this public health problem, and trying to, a lot of these patients are impoverished or have doubtful immigration status, all the same kinds of challenges you see with these populations at any setting. And they're like, look, if we get these people in front of us once, in whether it's in a maternal health clinic or an STI clinic or general health clinic, like we need to give them the works. Like we need to be doing this kind of testing all together. And the services, not just the diagnosis, but the services themselves need to be integrated. And this kind of optimization makes so much sense. It's sometimes quite frustrating for especially individual practitioners to be sort of forced institutionally into totally separate areas, where to try and do any project or start anything new, you now have to get alignment from 10 different bodies rather than work with one body. And so this concept of integration is really something we need to throw a lot of weight behind to demonstrate how well it works.
It makes me think, because it's the scourge of the AIDS response, in a sense, the scourge of the legacy of the AIDS response, the exceptionalism of HIV back in the 2000s and the 2010s, because we were just trying to get it on the agenda and raise money, which we were very successful in doing, in pushing the HIV agenda. The flip side is that we created a very siloed, vertical program, which seemed to meet the needs, emergency needs at the time, but which practically makes no sense at all. And so we've I think in the AIDS movement had a hard time opening up and letting 1,000 flowers bloom. But there's also a medical side to it, which is, and I don't know how you feel about this, but this sense that you have disciplines that are very protective. And even within infectious disease, you mentioned hepatitis B versus hepatitis C versus HIV. And then, of course, you have this underlying issue of tuberculosis. You raised it as in, relates to Peru. I was not aware of that, but of course it makes total sense. And of course, you see it particularly in Southern Africa. HIV has been one of the drivers of the increasing rates of TB over the last few decades. Do you think there is something that needs to be done in the way we train and educate and, dare I say, incentivized healthcare workers to think in a more holistic way?
Yes. The short answer, yes. And I guess, there's a few ways we could really look at this. When we look at guidelines that are released by like World Health Organization, they release guidelines for hepatitis. And what I'd really like to see would be a lot more emphasis on guidelines for integrated testing. And one of the things that I realized during this trip that we're sort of accustomed to is, World Health Organization or UN will kind of set these global guidelines. And one of the things I was hearing a lot, both at the conference and in my conversations during this trip, was and there was some specific research at R4P actually looking at this. Every country. I teach malaria at USC as well, and only a week or two ago, or 2 or 3 weeks ago in class, I was sharing the observations of a malariologist from 200 years ago who was saying, look, problem with malaria is it's 1,000 different diseases in 1,000 different places. And what is the best thing to do in one place might be the worst thing to do only 40 miles away. Now, we love our single bullet solutions, as humans. Like, we're always looking for universally applicable things. But it's really important to consider that these global guidelines can't just be handed down from above, that these global guidelines really need to take into account the individual needs of all these different countries and even different regions within countries. And I think like getting some global guidance that really starts emphasizing integrate, not just telling people you should integrate, but releasing guidelines that show how to integrate. by releasing strategies for integration, and especially, some of the health economics, stuff related to how much more efficient these integrated programs can be. How much, it's a lot easier to have one group that's doing like all this work than 12 different groups doing all this work. So obviously, like, people are always a little bit protective of their specialties, protective of their territory. But if national governments might get a little more encouragement and support at kind of biting the bullet and pushing some of these programs closer together and integrating these programs officially, I think that would be really helpful.
And there's a wonderful incentive, I think, facing all of us interested in healthcare, and that is cost efficiencies and decreasing budgets. And in many ways, if there isn't a greater incentive to treat people and treat them well and treat more of them, it means we have to join the dots. We have to integrate. So it's going to be forced upon us. And I guess, and this sort of brings us on to the diagnostics component of the conversation, I guess diagnostics ought to be the place where the magic happens. You mentioned folks coming into the emergency room with a broken arm. But for whatever reason, you come into a healthcare provider's facility in whatever context, and you could be offered an HIV test, a test for hepatitis, pregnancy test, who knows? How do we make sure that what we're offering people perhaps is, how much blood are you going to take from me? A platform that covers as much of the likely tests that you're going to need in a particular context, in a particular locality. How close are we to being at that point where we can do this?
I think, at least speaking from my area of molecular diagnostics, I do feel like I'm just starting to kind of see movement in that direction, the combining of individual tests into panels. For example, one of the things I heard a lot on this trip was, in relation to hepatitis B and hepatitis D. Roche has just released a hepatitis delta RNA molecular test as a research use only assay. And I had a number of hepatitis B researchers essentially say, can we have one test that does hepatitis B and hepatitis D? Some of those ideas, just combining all these things into kind of one-stop shop. Another complaint I often heard was that like within Ministry of Health or something like that, there's like one machine, that they obtained to test for HIV, and a different machine that they use for this, and a different machine for this. And there was, a lot of interest in, can we just have like a machine that has great big portfolio so we can run all these tests on one machine, which was one of my purposes in coming, was try to encourage and facilitate some studies happening with some of Roche's platforms that are, have a very large test menu, for that very reason.
And again, it sort of goes to the be careful what you wish for a challenge in front of us, because we've been trying to push diagnostics closer and closer to the people so that if you need a test, you can get it done quickly, you get a result quickly. And that's also taken us in the HIV front to self-testing, which throws all sorts of other questions open, which I want to come back to, particularly given the amount of gray hair I have and the experience of the HIV response over 30 years. But there is a sort of a push and pull here. Getting tests closer to people, so point of care, simple, rapid, versus providing a platform that's going to need these reference laboratories. You and I have spoken over the years of how important it is to have the hub and spoke, and that the hub, particularly these reference laboratories that are easily accessible by everyone to cover as much of the testing needs as possible, or reinforcing and confirming initial testing. How far are we in sort of reconciling these two? And we'll come on to what it looks like in country practice in a moment. But how is the research looking in terms of making this sort of balance work?
So I would say finally starting to make a little bit of progress in that regard. There's really sort of two avenues that people are looking at. One is moving more and more point of care, so much so that you've got like World Health Organization guidance going, look, in some settings, using two different rapid tests would be enough to like confirm diagnosis, right? So on the other end of the spectrum, you have access to central laboratory molecular diagnostics, PCR, down to like 12 copies, and so I always find myself, both as a member of industry and as an NGO leader who spent my entire practice working in the middle of the jungle, far from any electricity or water, any access to cold chain storage or any central lab testing, as trying to find ways not to go either or. Okay, this setting will only be good for some kind of point of care rapid test. This setting is the only setting where they can have central lab. I keep looking for ways to bridge those gaps. And one of Roche's products that is very interesting in that regard is the plasma separation card, which Roche developed specifically to try and link communities and populations that previously just have no access to central laboratory testing with the kind of performance and high throughut and sensitivity that you expect from a central lab. So it's like,
and that was a collaboration with Product Red, wasn't it?
Yes.
And particularly for mother to child transmission. I mean, I think it had a huge impact. It generated significant interest and helped the Cinderella of the HIV response diagnostics get to the ball.
And so I've been really trying to take this integrated testing model. Roche's claims on the plasma separation card as a sample type at the moment are for HIV-1 viral load. And very recently for hepatitis C RNA, which it also performs very well at. But I look at a tool like that and I think to myself, what about syphilis? What about tuberculosis? What about gonorrhea? What about hepatitis? And so actually, I probably have 5 or 6 studies running right now, like in Ghana, in Pakistan. I'm actually anticipating the submission of several proposals now from this trip, from this Latin America trip. I'm very excited with like sexual health clinic, a maternal health clinic, non-traditional settings to actually do this kind of hepatitis and HIV testing in, where they're going to be utilizing the plasma separation card to really kind of see what it can do and to kind of demonstrate the utility of something that doesn't require refrigeration and is temperature stable at 42 Celsius for 2 months in an envelope, to be able to link these underserved patient populations with central laboratory performance. So really excited.
So for people who don't live and breathe diagnostics, the plasma separation card, it's like a dry blood spot test, isn't it? You have
Correct.
a card and you send that off. And what you're saying with it being stable at 42 degrees for a few months is that it could get caught up in a country's slow reference, distribution and submission of samples.
Or, I mean, it could be in the trunk of a Ministry of Health Land Rover for 3 weeks, or, in a backpack of some community health worker on a motorcycle, that's working in these very remote settings and only periodically, or a very remote health center that only periodically is able to send any kind of sample, and even then not under cold chain storage. So that's the plasma separation card is really designed to try and overcome that lack of cold chain storage, which is what I'm really trying to demonstrate with it. So yeah, really excited about the possibilities for it, especially, I mean, we're really casting a wide net. I was experimenting, off-label with biochemistry, with other types of serology. And after this period of discovery, I'm very interested to see what kind of evidence collection I'll have to demonstrate, I hope, a much wider potential, for the use of this card for testing hopefully a wide variety of biomarkers. The dry blood spot is really great. A lot of people have been using that for a long time, but it's dried whole blood. And for molecular testing, the problem with whole blood is that all that pesky human DNA in the red blood cells and white blood cells gets in the way of your PCR testing. So the plasma separation card is essentially, it's like a dry blood spot, but with a very fine filter over the spot. So the filter pad or the absorbent pad sucks the blood through this filter, and all the whole blood products get filtered out. So you're left with a dried plasma spot, and that gives you much cleaner opportunities for molecular PCR.
I love that innovation, particularly because it doesn't involve complex technology, cartridges, Bluetooth and wireless access that may be difficult in many settings. And I guess this gets to the other point. You've been looking at access to diagnostics across the world. What have you been seeing in terms of lower middle income countries? Just how many people do get access to diagnostics routinely?
I'm glad you asked. I'm glad that you mentioned middle income countries, because I would say that my biggest insight from this trip was every person I talked to, they're a Ministry of Health doctor, they're a research, didn't matter who, affiliate members, whoever I talked to, if they were from a middle income country, they said the same thing, which was, we are very frustrated because we understand that most, money from international sources, money from World Health Organization, external support is really, global access pricing from industry is really focused heavily on low income countries, the countries with the greatest need. And they were essentially like, look, we get that, right? We understand prioritizing resources for where the need is greatest. They said, but we really feel left out. We middle income countries essentially feel like, and forgive me if this is exactly the way it was said to me by at least 6 people, that we're not shitty enough. Like we're not in bad enough shape to warrant any kind of consideration or support. They're like, oh, you guys are a middle income country, you're fine. And they were like, look, you have a very low income, high need setting. You put in this much resource and you get maybe this much benefit. But we middle income countries, maybe you give us this much support, we could get this much benefit because we have some infrastructure and some programs and motivated people and knowledge resources, but we're just not in bad enough shape to warrant much attention. And so the middle income countries, I learned, have this real sense of feeling left out. It's real like middle child syndrome, actually, like where they're like, oh, they're fine. They're not so young that we need to pay attention to them, and they're not so old that they don't need any attention. But they really get ignored. And so the message I'm really carrying back to, at least to our industry is we really need to look more closely at the way we evaluate opportunities for supporting middle income country, activities, because these are the countries that are best positioned, to actually make real gains. I actually was sitting a few months ago at some other event next to a person in Los Angeles who was on the homeless council, like the county board trying to combat unhoused, situations in Los Angeles, which, as many people know, is very severe. Mm-hmm. And he expressed the exact same thing to me. He said, right now, the vast majority of resources are prioritized for the unhoused who have the greatest need. He said, and you get that. That makes sense, like ethically. He said, but like I routinely, see like a recently homeless family where both parents are working. They've just become homeless. They're all living out of their car. The kids are actually still in school. No one yet has a big substance abuse problem. And he said, those, if I could give them this much support, they'd be back, housed again. They stop that downward spiral. But I rarely have that support for them. Most of the support is for people with the greatest need. He said, but those are folks that have mental health problems and criminal records and no job skills and substance abuse problems and histories of abuse. And so he said, you can pour resources at those candidates, but your gains are quite modest compared to what you could get if you supported the middle income country version of the unhoused, which would be like a recently homeless family.
I'm nodding my head vigorously at everything that you're saying, because this is a really timely conversation. You've got a large pharmaceutical company that had some extremely interesting data at the Lima AIDS conference about the performance of a long-acting injectable for prevention, and it's announced an access strategy globally, which is terrific, in advance of the product actually being fully approved for prevention. But it's getting criticism that access program is not available to middle income countries. And, this is a problem. Who pays? I remember a South African activist saying to me a good few years ago that South Africa should not be treated in the same way that you would treat Zimbabwe, when South Africa had just put an order in for, I think, 4 or 5 new submarines. So it's about national prioritization around health. But again, it's a little bit like, the chicken and the egg, and you get around that by saying, if you build it, they will come. And if health policymakers know that it may not be at the same level of affordability or accessibility as you would in the poorest settings, but if they know that it is going to be doable, there's absolutely a coming together, I think, that can happen. And I think you are spot on about the folks who are just getting themselves into housing, what up in Northern California they call the marginally housed. And I think that's absolutely right. There've got to be services, particularly around diagnostics, because you need to know what you're dealing with. You as an individual need to know what you're dealing with. And if you have limited access to your doctor or nurse, you want to make best use of that time. And the best use of that time is to say, well, let's, as well as checking your viral load, if you're HIV positive, is your treatment working? Let's see how you're doing with these other potential diseases. Hepatitis is a grand example. The hepatitises, the viral hepatitises, are a grand example of that. So I'm really glad you've raised that with us. So going forward, looking at what you're doing with the company Roche, but also with your own nonprofit work, where do you go from here in building an integrated approach to promoting diagnostics, to promoting integrated access to diagnostics?
Well, I mean, and as an aside, without naming any names, let's just say a lot of people had a lot to say, during this, Latin America trip of mine about the, kind of new, permission to manufacture generically of this particular medication, and a lot of grumbling from middle income countries about, and there was a certain cynicism too, and once again, we're being totally left out of that, even though we're in the best position to make the best use of this. It was there was definitely some strong feelings about this. So yeah, I was like, noted. What we can do, I guess with my floating doctor's hat in my own organization, we really do 2 things, right? We're providing health services, but one of the ways we support those health services is by inviting foreign physicians and health workers and students to come and train with us. And the funding from that training program really supports the medical program itself. And we're constantly emphasizing to them, don't forget to ask the patient how they're sleeping. How are things at home? How are they coping? What are they eating? They came for their broken wrist. You're going to ask all these other things. Ask them the questions that will let you know, like, should I offer them an HIV test? Do they fall into a category where they're supposed to ask them if they've ever been screened for hepatitis B? Have they been vaccinated for hepatitis B? If not, offer them the test. And so, certainly the messaging to providers really needs to encourage, like, hey, don't forget to ask about this. And the other is, and this I think has not been done as effectively yet, it's to really aim that messaging at patients. And I kind of look at how healthcare has progressed in the US, and especially over the last 10 or 15 years, I feel like the likelihood that patients are going to really get what they need when they go to their provider is becoming increasingly dependent on the patient to know what it is, that they really need, so that they can ask for what they need. every story I hear is, them going, I went and then the doctor did this. And then I asked them, well, should I also have this? And the doctor went, that's a good idea. And they ordered it. And I like the idea of not just trying to empower and support physicians to do this kind of more paternalistic model. I really like the idea of making sure that patients, understand, what their options are, what their health needs are. I saw actually only recently, I had no idea about this, that the World Health Organization has, and I have no idea how new this is, has embarked on a really big social media campaign. I guess they have like 800 content creators. They said, as the website said, they reach like 150 million people. So I just found out about this, and I had no idea like what outlets and platforms they're using. But I plan to reach out and kind of see what industry can do. Like if they're working with content creators, like industry is forever creating content to educate patients, to educate providers, to educate policymakers. And of course, the traditional ways we get that information out doesn't always reach people. You put it up on a website somewhere hidden on your industry's 8 pages. Not every patient in the street is going to access those. But if you can reach patients where they already are on the social media platforms that they're already using, there's a real opportunity to get this messaging, to get the right and accurate messaging out there so that patients know what they need. And I've really
that was the whole reason for setting up a Shot in the Arm podcast. I spent 20 years convening and then drafting reports, expert reports, action reports, calls to action. They look great as published materials, and they went onto people's shelves, and nothing ever happened with them. And I think a really big interest for us, of course, is LinkedIn, YouTube, Spotify, particularly, to reach an audience that perhaps wouldn't necessarily think about, say, diagnostics as part of a health policy work. We're very niche, of course, in speaking to health policy folks, speaking to ourselves, one might say. But there are different ways of communicating and reaching people. And, our assistant producer who does a number of podcasts herself, Waisha Raphael, looks particularly at who influences young people, who do they listen to and who do they trust? And influencers are absolutely essential in that, and presenting information in ways that make sense, ways that, we're the other end of the spectrum, us perennial teenagers might not think is entirely relevant. So I'm with you entirely. And I think, a next wave of integration of healthcare, of wellness, is going to have to include influencers, people, trusted sources of information, or information sources that are trusted by people, as entry points. Of course, the 1,000 flowers blooming model also involves perhaps 1,500 weeds emerging at the same time. So that whole information, misinformation, and disinformation. But nonetheless, I think you're absolutely right. But what do you think companies working in the health sphere can do to capitalize on that, support that, without being drawn down into, for those of us who still watch terrestrial cable TV during the advert break, seeing the long list of pharmaceutical adverts?
The 1,000 weeds was actually a really good example, because the weeds were already growing, right? The weeds are going to grow no matter what we do. And so I have heard people kind of go, well, what's the point of like messaging out there, because there's all these weeds. And I, of course, take the opposite view and say that's why it's so important to plant these flowers. If we can plant enough flowers, maybe people will start seeing the flowers, not just the weeds. And people will be able to make up their own minds. I think, your point about using trusted stakeholders is the key. A lot of people for all over the world, for all kinds of reasons, don't necessarily trust messaging that comes from their government or comes from industry or comes from, but everyone has some kind of stakeholder that they really listen to. Panama, outside of social media, did something interesting during the pandemic. They were trying to roll out their vaccine program and, not necessarily wanting to spend tens of millions of dollars to establish a new government agency to disseminate information. Panama, one of the things they did was they called like the head bishop of Panama and rabbi and imam, all the major religious leaders, and said, hey, you guys have an existing network of trusted community leaders that extends from like the capital city all the way down into all these tiny little remote villages. Can we give you guys the information about the vaccine that we want to get out, and can you disseminate it through all your stakeholders who are already trusted community members? And by giving them the right information, it also prevented them, by giving them flowers, it also prevented them from handing out weeds based on misinformation. And I thought that was such a typical lower middle income country efficiency solution. Of course, I asked some of my, a couple of friends who are priests in the US, was like, did anyone in the US come to you guys about that? And they were like, no, of course not. Nobody talked to us about that. And I was thinking, what a missed opportunity that would have been, to get messaging out, because plenty of people in the US heard messaging from CDC or government or health agencies and were automatically skeptical just because, people in the US are often like that. So really finding out who these trusted stakeholders are. This is conversations that we've been having in Roche, with the last year, like where are people getting it? I saw that not at days this year, but last year, there was an interesting presentation where, and I'm pretty sure it was with Grindr, that app, which has ads on it. They started including ads that were about PrEP and access to PrEP. And through the ad, you could actually select a link that would link you to receiving like self-testing materials through the mail. And I thought, this is great. We always talk about reaching people where they are or where they live, but we've so far really focused on that physically. And we've sort of neglected digitally. Like, where can we reach people digitally? That's why I like coming on a shot in the arm. Typically industry might put on some kind of event at a conference where if 60 physicians come, that's a huge success, and it's very expensive. And who knows, of those 60, what will actually come of that? And the first time that we did a podcast and I took the analytics back, about 3 or 4 weeks later, and we were able to go like, oh, and by the way, 50,000 people have listened to this already in like 15 countries. A lot of people within our company were like, wait, what? And it really spurred a lot of interest in Roche even starting to make their own podcasts and looking for these other sources and ways to reach providers, policymakers, and patients where they're already hanging out, and really like identifying the key individual agencies or individual stakeholder influencers and partnering with them to deliver the messaging, I think is really the next stage in the evolution of trying to meet these information challenges.
And we have to learn that people are consuming content in very, very different ways. Not going to get into politics, but you'll notice that in the United States, both candidates have been spending a lot of time on podcasts, and podcasts that are not, organized by the New York Times or Politico, but really sort of getting out there. And I think, that is the future. That's absolutely the future. There was one other area, Ben, turning track, that I wanted to come back to. You mentioned the co-infection of HIV and TB that you were seeing in Lima, in part, I guess, caused by the flow of refugees coming from Venezuela. But I wonder if you could reflect a bit more on that co-infection and again, where integrated diagnostics could help drive effective care for folks.
Sure. I mean, so here you've got these two diseases, one of which, let's say for practical purposes, can't be cured. Yes, I know. We just had another patient cured, the oldest patient yet. So awesome. But for practical purposes, a disease, HIV, that's going to require lifelong treatment and lifelong monitoring. And then on the other side, you've got tuberculosis, this condition that very easily develops resistance, that requires taking multiple medications for 6 months, 9 months, longer if it's resistant. And the consequences, of course, of interrupting that treatment are catastrophic from an individual and public health standpoint. I would say of the patients I encountered in Panama who had in rural settings where I work in Panama, patients who had ever commenced treatment for tuberculosis, I would estimate that and this is again, just back of the envelope, like what's my anecdotal experience? I would say 1 out of every 100 to 200 completed their therapy. That the other 99 to 199 interrupted somewhere in that region. Sometimes, they might miss an appointment because they had to travel 2 days to get there, and then they were worried about going back because they were worried they'd get in trouble, or they stopped because they felt better, which most people, when they start their TB treatment, feel a lot better really soon. And then just like, patients taking amoxicillin for, chest infection in the States, take this for 10 days. After 5 days, they're like, I feel better. And they stop taking it. And then resistance. So, both of these conditions are ones that require a pretty high investment of clinical time, like with the patients. And you can either do that twice in 2 separate settings, or you could do this once in one setting where you're monitoring and treating their TB at the same time that you're monitoring and treating their HIV. And this is where, like in diagnostics, having like one machine that can do both, potentially having, sample types or tests, like where one can do both, things like that. These would all be big advantages in being able to provide patients these care, because it's almost not worth like just managing a patient's HIV if you ignore their TB, and vice versa. Because if you ignore one and not the other, whatever you did with one was almost a waste because the other one is going to get them. And so these are not just like, well, it's more optimal. This is where if you want your HIV treatment to be worthwhile, you can't afford to ignore their TB, or vice versa.
And this is where funding mechanisms like the Global Fund, which covers AIDS, TB, and malaria, but the AIDS and TB particularly, can really play a role in incentivizing that approach to an integrated, comprehensive approach to diagnosis and care. Well, look, Ben, we're getting up to the top of the hour. Is there anything that we've missed? Any nugget of wisdom from your travels these last few months that you think our listeners and viewers might benefit from?
Yes, I have one more observation that I think might have real value both for industry and for all of the people trying to actually combat these. Traditionally, as an industry person trying to develop new evidence, you're partnering with researchers to do studies that use your test, in a particular way, or check its performance against other tests, things like that. Most of the time, traditionally, we really try to target like the most famous investigators, right? Who's like the main KOL in this space, things like that. And when I came into Roche, you know that a lot of our studies for HIV and hepatitis were at that time, really heavily located in Europe, like with really, a lot of awesome investigators, that I've had, I've learned a lot from working with. But I really wanted to try and move a lot of our research into the countries and regions where the burden is the highest, where you've got a combination of like young and hungry practitioners and people who really want to get into research, but don't necessarily command big academic departments and army of graduate students for their data analysis and publication support and all that stuff. And also really experienced physicians who haven't maybe published that much yet, but have spent 30 years in the front lines combating these conditions where they are and have this wealth of knowledge and experience. And I've found ways to really engage the Roche resources to support these earlier career stage investigators or later career stage investigators who haven't been able to leverage their experience on the world stage yet to really start getting published and getting research at some of these big conferences and being able to establish a presence. And of course, from their point of view, this is really useful in helping them develop professionally and helping them develop the evidence that they know is needed to convince local policymakers what needs to be done. From an industry point of view, not targeting those researchers for support is a huge strategic blunder, because these are the researchers who will become your most loyal collaborators, and the ones who 5 years from now, 10 years from now, will be making the guidelines for the ministries of health in their countries, making decisions about what platforms of diagnostics or programs to have. And so that is definitely my advice to industry, is to don't neglect the young and hungry or very experienced but not well published researchers who have faced real barriers to being able to do research, because they have a lot to offer. Really, these are the folks who are going to be leading the charge, especially in low and middle income countries.
And it's sort of a physician's or a researcher's perspective of nothing for us without us. So yeah, amen to that, Ben. Well, look, with that, I'll let you get back to packing for your flight home. We actually live in the same state, although the opposite ends, and we should really sort of try and do one of these in person. So whenever you're up in Sacramento, or there's an invitation for you to come up to Sacramento and record in person, it would be great.
That would be fun. Count me in. And Croy is going to be in San Francisco in the spring, so that might.
That is right. Yeah. We'll do a lot of stuff from Croy. Oh yeah.
You'll be at Croy this year?
Oh hell yes. Yeah.
Awesome.
Yeah.
What a great conference. All the really juicy research gets saved up for Croy, I feel like.
Yeah. And I mean, what they will think of me saying, will you be at Croy? Hell yes. There we go. Okay, Ben. Well, fair winds, as you say. Travel safe, and we'll see you soon.
Thank you so much, Ben. Always a pleasure.
Well, that's it for this episode. Thank you to Ben LaBrot for all of his insights. Thanks to Erica Spera, our director and producer from NewsDoc Media. A big thanks to Waisha Raphael, our assistant producer. And finally, a big thanks to you. Don't forget to subscribe and give us 5 stars. Hope you enjoyed this episode. Have a great week and a safe week, everyone.